Now that you know how ARDS was discovered, let's discuss criteria required to diagnose a patient with ARDS and how that criteria has evolved to its current state. We will start with the American European Consensus Conference criteria and then move on to the contemporary Berlin criteria for diagnosing ARDS. ARDS is an acute, diffuse, inflammatory lung injury that leads to increased pulmonary vascular permeability. This manifests clinically as hypoxic respiratory failure that appears on radiographic imaging as bilateral opacities. During the 1994 American European Consensus Conference, thought leaders were tasked with creating a diagnostic criteria for ARDS. The definition that emerged included the following: acute onset, bilateral lung disease confirmed by X-ray, a PaO2 to FiO2 ratio of less than 200, and exclusion of cardiogenic pulmonary edema by requiring a pulmonary capillary wedge pressure of less than 18. This criteria established a standard for the time, but as literature and research advanced, the definition required an update. This was partially due to movement away from pulmonary artery catheters and a transition to include the use of computed tomography scans, or CT scans, to diagnose bilateral lung disease. Later, in 2012, there was another consensus conference, this time held in Berlin. There, an updated set of criteria for diagnosing ARDS was created, given the changes in imaging and management noted previously. This included some of the original criteria, but with further specifications and parameters. For example, patients must still have acute onset. However, acute onset is now defined as onset progression within 7 days. Bilateral lung disease also remains, but now any imaging modality may be used to make that diagnosis. The PaO2 to FiO2, or P to F ratio, was changed to a value of less than 300 from 200. This was done to include a category that was previously referred to as acute lung injury, or ALI. Patients with a P to F ratio between 200 and 300 fell into this category. To simplify the nomenclature, all P to F ratios between 0 and 300 now fall under the umbrella of the ARDS diagnosis. A PEEP, the positive end expiratory pressure, of greater than or equal to 5 was added to the oxygenation criteria. And acute pulmonary edema is still in the exclusion criteria, but the physician is allowed to rule this out using any available data. Let's take these criteria one by one and discuss in a little bit more detail, starting with acute onset. By defining acute onset as progression within a week or less, we are able to exclude chronic lung diseases that might accidentally be classified as ARDS. For example, idiopathic pulmonary fibrosis may present with bilateral severe hypoxic lung disease, but does not behave like acute respiratory distress syndrome. When the Berlin conference convened, they realized that there was poor inter-observer reliability of chest radiograph interpretation. To address this, they expanded the imaging modalities to include CT and created example radiographs. Exclusion criteria were also further defined to include effusions, lobar or lung collapse, and pulmonary nodules. When discussing the origin of edema, it was recognized that there was declining use of pulmonary artery catheters and that cardiogenic pulmonary edema in patients with cardiac failure or volume overload could present simultaneously in patients with ARDS. The Berlin criteria provided guidance that if there was not a risk factor for ARDS present, then an objective evaluation, such as echocardiography, would be required to help eliminate the possibility of hydrostatic edema. Of course, this makes sense because ARDS is defined as a disease of nonhydrostatic pulmonary vascular permeability. When looking at the oxygenation criteria for ARDS, the PaO2 to FiO2 ratio remains in use to make a diagnosis of ARDS. The current definition uses any P to F ratio less than 300 to delineate if a patient meets criteria for ARDS. The categories remain the same, but the naming changed slightly. Patients with P to F ratios between 201 and 300 were previously said to have acute lung injury or ALI. Patients between 101 and 200 had moderate disease, and patients less than or equal to 100 had severe ARDS. The Berlin criteria eliminated the term acute lung injury. Instead, all P to F ratios now represent ARDS, and the values between 201 to 300 are termed mild ARDS. Other variables evaluated at the Berlin conference included PEEP of greater than or equal to 10, static compliance less than 40 milliliters per centimeter water, and minute volume greater than 10 liters per minute. This is a surrogate for increased dead space. When evaluated, these ancillary variables did not identify patients with higher mortality and were therefore excluded from the final definition in favor of a less complex and more user-friendly ARDS definition. Now that you can handle diagnosing and staging the severity of ARDS, it's time to take a view of ARDS in terms of its pathology.
So I hope you liked this video. Absolutely make sure to check out the course this video was taken from and to register for a free trial account which will give you access to selected chapters of the course. If you want to learn how MedMastery can help you become a great clinician, make sure to watch the About MedMastery video. So thanks for watching, and I hope to see you again soon.